Welcome to Disorders and Therapy. We're going to spend a lot of time talking about these disorders this week in class. Please pay attention because I'll be able to give you a lot more depth than what I'm going to be able to do here in the next couple of minutes. The one thing I want you to know is that you should remember the DSM-5 or the Diagnostic Statistic Manual of Mental Disorders, and we'll talk about what that covers. But essentially, this is a diagnosis manual for mental illness. Now, having a copy of this in your house or in your hand does not make you a psychologist or a psychiatrist. What it does is it gives you much of what you would need to look for to classify or diagnose someone as having a psychopathology or a mental illness. But again, you need things like their case history, any of the environmental factors, any of their thought process, their cognitions, family history. There's a lot of things that go into diagnosing. So just remember that for a lot of mental illness, it's an extreme expression of things that we do normally. First category of disorders we'll look at are anxiety disorders. The first anxiety disorder that you want to look at is generalized anxiety disorder. This is going to be marked by prolonged expressed anxiety with no real trigger. So at the heart of our anxiety disorders are the sense of being anxious. Anxiety is something you've all experienced. You guys have all gotten up to give a speech in class and felt your heart thumping and your palms sweating and your mouth go, cotton mouth and all of that. That's anxiety. Now imagine having it with no real reason for it. Panic disorder is it is an anxiety disorder. Panic disorder is when out of the blue, you all of a sudden feel this intense sense of panic. You have anxiety, but it's like ramped up anxiety. Panic disorder is often going to exist with agoraphobia. People start to become fearful of when they're going to have their next panic attack, and so they don't go out into public, and then they start to become phobic of public and they want to stay locked in their homes. Now, agoraphobia literally means fear of the marketplace, but again, what it means is fear of going out and being in crowded places with lots of people where you are really kind of afraid that you might do something that would embarrass yourself. And in this case, people are afraid of when their panic disorder may show up. Phobias are not what most of us have. Most of us say we are something phobic, and what we mean is that we really strongly dislike. I hate clowns. Now, if I was walking down the street and I saw one, it's not going to cripple me. I'm not going to go into a panic attack. I'm not going to start to have kind of overwhelming cognitions. I don't think about them every single day. I just don't like them. So it's not a phobia. It's a strong dislike. Make sure that you don't call things that you really just don't like phobias. It's incredibly insensitive. People who have phobias, they're crippling. They think about them, they impact, part of the diagnosis for this is that it has to impact them on a regular daily basis. It's probably not what most of us have. So again, phobias are going to be pretty extreme, and at the heart of them, they have the feeling of anxiety. Social anxiety disorder, or also known as SAD, don't confuse that with seasonal affective disorder, which we'll talk about in depression. Also is known as social phobia. And again, this is the fear of doing things in public, not just speaking, but it could be things like eating, being in groups of people and having people laugh, and all of a sudden you start to feel anxious about it. That's going to be social anxiety disorder. OCD used to be part of anxiety disorder, and so did PTSD, but they felt that this actually was a bridged type disorder, and they felt that OCD and PTSD actually bridged anxiety disorders into bipolar and mood disorders. So they felt like it didn't really fit anxiety alone. Obsessive compulsive disorder is not a strong preoccupation with orderliness. It's really annoying when people say they have OCD and what they have is they really like the color purple, or they really like when their bed is made a certain way. That's not obsessive compulsive disorder. Obsessive compulsive disorder, you have a obsession, literally a repeated thought process that you cannot erase. And in fact, this disorder actually manifests itself with overactivity in the frontal lobe. So your frontal lobe is firing, saying, focus on this, focus on this, focus on this, focus on this, to the extent of healthy other functioning. And the only way that you reduce the obsession or the thought and the fear that it brings on is with a compulsive behavior. Now, the compulsion doesn't actually even have to make sense. It just has to get paired up and reduce the stress. So this is reinforced by negative reinforcement. You avoid the feelings of stress associated with the obsession by doing this compulsive behavior, which increases the compulsive behavior. So germaphobes, People with a preoccupation with germs are very common. Checkers are a very common way of dealing with a compulsion. So the obsession might be about germs, and the compulsion might be to wash your hands over and over and over again, never quite getting it clean. And we'll talk more about what OCD is, but remember, it's marked by obsessive thoughts and compulsive behaviors to reduce the obsessive thoughts. PTSD is another one that is not technically just an anxiety disorder. It can be marked by some hallucinations or false sensory experiences. There is a high level of anxiety, and it can also have some elements of depression in it. PTSD, you are looking at somebody who has unwanted and intrusive thoughts, dreams, or reliving of previous traumatic experiences that are completely unwanted. And we'll talk more about those in class, but just to kind of give you a refresher. Somatoform disorders. So I told you guys we have an area of our brain called the somatosensory cortex. It's where we feel touch. Well, when we look at somatoform disorders, that usually brings in, strangely enough, parts of the somatosensory cortex. So conversion disorder primarily does this. Conversion disorder is when you have a high level of stress and it expresses itself in the inability to move or normally function. So you're really stressed out and all of a sudden you can't move your arm. You're really stressed out and you have hysterical blindness. Your eyes stop functioning. Usually it's going to be things like numbness in an arm or the inability to move a leg or something like that. But something like hysterical blindness is a conversion disorder. Hypochondriasis is where you get what we'd call people being a hypochondriac. Now, this isn't just somebody who thinks that they're sick. This is somebody who literally can also feel like they are manifesting. So they feel like they have the sore throat when they hear that someone else has strep, and they feel like they have a lump and so they really do see themselves as consistently ill. Dissociative disorders, at the heart of them, have dissociation, your ability to break from reality. Now, this doesn't mean hallucinate, and it does not mean delusions. That's not what I mean, break from reality. I mean, this is where you literally no longer are in the driver's seat. Now, a lot of people say that these things aren't real. They're very similar to what happens when people get hypnotized, except that this is unwanted. Whether it's real or not, whether dissociative identity disorder, which is what people call multiple personalities, is real or not, people do suffer from it. And I use the word suffer because they don't want to do whatever it is that they're doing. There is a real physiological impact going on that is beyond just their choice control. So it's not attention getting. So for dissociative disorders, the core personality or the person doesn't seem to be there. It seems to be something or someone else. So DID, or dissociative identity disorder, is what used to be considered multiple personalities, and in this case the personality fragments. There's a core personality, but due to stressors or other events, other personalities will kind of come in and take over for certain situations. During that time, the core personality may not know what's going on. You can have co-consciousness where the other personalities know about each other. And the big difference between dissociative identity disorder and schizophrenia, in DID, the voices are inside your head. Schizophrenia, the voices are outside of your head. Dissociative fugue is going to be what we would consider dissociative amnesia with a fugue state, which is now the newer term for this. Fugue just means that the person travels. So it's dissociative amnesia with travel, and we'll make that make more sense here now that I am going to explain to you dissociative amnesia. Dissociative amnesia is more like Hollywood amnesia than what most people think of as, anterograde or retrograde amnesia. Dissociative amnesia is due to a big stressor. The person loses all memory of personal information but still can maintain specific abilities. So you are a doctor and you come home and your wife is cheating on you and you go, oh my gosh, I don't remember who I am. But as you're wandering around trying to figure out who you are, someone has a heart attack and you run in and, I don't know, crack their chest open and somehow save their lives. I don't, bad example, but you get what I mean. It's what we usually see in soap operas. It's that kind of extreme. The person really just functions but blanks out. They may actually have this last anywhere from a couple of hours to maybe even sometimes a couple of days. Dissociative fugue has been known to last up to a couple of years. Very, very, very rare. We're talking in like less than 1/100th of the population. But dissociative fugue had also been known to have people go and establish new lives way before the digital age, when it was much easier to do so because they couldn't remember who they were. Mood disorders are really common. Anxiety disorders are I believe, the most common, with mood disorders in a really close second. Everyone's been depressed. Being depressed does not necessarily mean that you have a mood disorder. You're supposed to be depressed. You shouldn't be happy all the time. So you shouldn't also be sad all the time. It's just, it should be, you should have a healthy mix of kind of the full range of emotion. So major depressive disorder is somebody who is going to have chronic low feelings of self-worth and hopefulness and all these other things. They're going to be majorly depressed. It has to last for, if I'm remembering correctly, at least 2 weeks, up to a month for it to be diagnosed. Dystemic disorder, which is now considered to be called pervasive depressive disorder, is when someone for about 2 years doesn't seem to have a happy day. They just always seem kind of depressed, but it's a minor version of depression. So it's not debilitating like major depressive where it will keep you in bed and keep you unable to really kind of get up and feel motivated to move. Dysthymia or pervasive depressive disorder, that one is more just you get up, but you're just never really quite happy. And that is diagnosed by a 2-year period of it. Seasonal affective disorder happens to people who live in areas that tend to have very low light during the winter months. In other words, little exposure to sunlight. Treatment for that is phototherapy. They just sit in front of a lamp that gives them the correct vitamin D that would come from the sunlight. And again, you can't just sit there and sit in front of a regular light bulb. It has to actually be something that emits rays much like the sun. Bipolar disorder, you have someone who goes between mania or states of pure unrelenting kind of like positivity and energy, and they're just ping-ponging off the walls, and they make really kind of horrible decisions because it's done in this point of just like almost like you on like 10,000 pixie sticks type of mentality. And then they come down to a depressed state. Bipolar disorder comes in bipolar 1, bipolar 2, and clothmic disorder. And so they're all different variants of the same thing. The one thing you need to know for bipolar disorder is that you go between these two extreme poles. There is a stop off at normalcy. So the person isn't up and then down and up and down, and it's not equal. Usually depression tends to be the greater hallmark than the mania. Schizophrenia or schizophrenic, oh God, what's the new term for it? It'll come to me later. Knowing it's schizophrenia is fine. It's an umbrella term, and so people with schizophrenia can have delusions, which are going to be false thoughts like, I am God, or the CIA is after me. They can have hallucinations, which are false sensory experiences, where they sit there and they believe that they see a floating head with tentacles in the corner, or that the light on their digital clock is flashing 666. They can have language disruptions. They can have what we call word salad, where they have jumbled speech. You do have to know the personality disorders, and there are quite a few. So no borderline, antisocial, avoidant, narcissistic, schizoid, and histrionic. The one that I think most people have the hardest time with is the histrionic. Just remember, it's when people are like hysterical. And I don't mean like hysterical as in laughing. I mean hysterical as in everything that ever happened to them is like the worst. Okay, so we're skipping ahead to therapy. Now this one we might need to cover again in another review because I'm not so sure how close we're going to get to getting all of this in before the AP exam. When we look at therapy, you are going to have therapy from different areas, and some of these things, nicely enough, we've talked about when we talked about them in class. So psychoanalytic therapy, again, this is that talking therapy where you sit down and you talk to your therapist. Now, what they say when they say resistance is that anyone that sits down and talks, when they're doing free association, they're resistant at first. You're not going to come out and say all the horrible things that you have going on inside your head. You're going to block them. You're going to shift them. So the first goal of the therapist is to get through the resistance while using free association. The other thing that the therapist might experience is something called transference, where whether good or bad, the subject starts to transfer their emotional feelings onto the therapist. So you're there because you're talking about the horrible relationship you have with your parents, and you find out that you start to really just hate your therapist. You have done transference. they don't necessarily always think of that as a bad thing. It's getting the emotions out, it's getting the situation out, it's dealing with it. So it can cross line if it starts to become something like sexual, where you start to feel attracted to, then ethically they are bound to give you a different therapist. Humanistic theory, we've talked about client-centered therapy. The one thing that I didn't mention is the term active listening. Active listening is where you hear what the person says and then you reformulate it and give it back to them in a way that allows them to hear themselves what you had to say. This can be really effective or it can be done very poorly. If it's done very poorly, it's very hard to reach people with. So you sit there and you tell your therapist, I'm really stressed out. I just hate my job. And the therapist goes, what I hear is your job is really stressing. And you're like, yeah, I just said that. That's not good active listening. Good active listening, you sit there and you go, I really hate my job. I'm really stressed out. My boss is blah, 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 and blah, blah, blah. And the therapist goes, all right, now hearing what you had to say, it sounds like you have a lot of focus on your boss and that he might be what stresses you out. Am I hearing you right? That kind of active listening is beneficial because you go, oh, I talked mostly about my boss. I didn't even realize I did that. Or no, I just maybe I'm thinking more about him, but no, I really think this is. And so it helps the person kind of talk about what they need to talk about. Behavioral therapy. We've covered these. Counter conditioning. So you are going to take a person who has a behavior and you're going to try to condition it in a way that changes the behavior. It's behavior modification. So I want my kid to stop hitting his sister, so I'm going to condition the behavior out of them. Token economies, do things for rewards. Systematic desensitization, we've definitely talked about. I would also put aversion therapy in here. That's another type of behavioral therapy. Cognitive therapy, my favorite, cognitive behavioral therapy. This is the therapy for obsessive compulsive disorder. Change the way they think, break the reinforced pattern of behavior, get them to stop doing the compulsion, and get them to understand that maybe their obsession or their thought process is irrational. Hit both of those, you got cognitive behavioral therapy. You do need to know the medications, but really more important than just the medications, you need to know the term tardive dyskinesia. It's a weird looking word. Tardive dyskinesia happens when someone is on antipsychotics. So your antipsychotics or what's called your neuroleptics, clozapine, clozaril, thorazine, you should have a general idea or eye for those. The zines is usually what I call them. If you have someone who's on an antipsychotic, antipsychotics are for schizophrenia. You have someone on those and they may actually start to over time develop tics or twitches. Once these set in, they're not reversible. Then you have your antidepressants, Prozac, Zoloft, Paxil. Those are all what we'll call selective serotonin reuptake inhibitors, or SSRIs. Selective serotonin, they select serotonin, reuptake inhibits. It prevents serotonin from going back into the axon. It keeps serotonin in the synapse, and it continues to fire happy messages, or at least it should alleviate the depression. Really, I would say Prozac is one of the big ones. Zoloft, Paxil, you should know those. Lithium. I always use lithium, but I feel like it's kind of an old reference. Anyone who ever listened to Nirvana or knows who Kurt Cobain is, their album Lithium. Lithium is the medication for bipolar disorder. That's really what you need to take from that one. Lithium, bipolar disorder. For anti-anxiety, you're looking at Valium or Ativan, things that kind of bring you back down. They don't let you get too up. And then again, bipolar disorder, mood stabilizers, keep you from going between the two poles. That would be lithium. And I told you guys what you need to know for tardive dyskinesia. Again, make sure that with tardive dyskinesia that you are looking at the antipsychotics or schizophrenia or psychotic disorders. All right, alternative therapies, ECT or electroconvulsive therapy. ECT, this is when you have a electrical current experienced by the subject. Usually we'll use ECT if we're trying to disrupt memory formations. It helps with post-traumatic stress. You can do that while someone is experiencing or trying to remember something. It disrupts the memory and may actually break the memory. It used to be used for depression and mood. RTMS. When we're looking at RTMS, you're looking at transcranial magnetic stimulation. And again, we know that we'll use this for things like obsessive compulsive disorder, in some cases, OCD. It's used heavily for schizophrenia anytime that you want to depress some of the firing in certain areas of the brain. So use magnets, it depresses or slows any of the firing in those areas. EMDR, this one is used a lot in Criminal Minds, which I find kind of laughable because there is a little bit of controversy about whether or not it works. It's called eye movement desensitization and reprocessing. In other words, it's used with PTSD. When the person is remembering or bringing up the memory, they have to move their eyes back and forth rapidly. And the idea is that this should help them process the information easier, and it allows the person to talk to them and get them to kind of bring in new information. I really would be very surprised if you get anything about that. So I almost feel like you should scratch it, but just have it in your, your pocket in case you need it. Last one, lobotomies. Lobotomies, it's intentional brain tissue destruction. Used to be done with a very simple ice pick type looking skewer that would just get shot through the orbital bone in your eye, and then you would scramble back and forth and pull it out. People that you want to know for therapy: Freud for the psychoanalytic, Rogers for client-centered, active listening.